All right, I think we're set to start here. Welcome everybody to another edition of Peers. I'm Adrienne Tadella. I'm the Knowledge Management Specialist here at USU Center for Global Health Engagement. And these practitioner education exchange and resource sharing webinars, or Peers for short, are meant to provide a space for your knowledge sharing and discussion of trending topics within the global health engagement enterprise, bringing SMEs and experts on our panel here and a discussion among the practitioners in the community. So for this fourth session, we will put a spotlight on understanding global health engagement through the lens of infectious disease surveillance. I'm really looking forward to the presentation in just a few moments. But before I pass it on to my colleague, today's facilitator, Mr. Julian Lantry, who's the research project manager here at the center, I did want to remind everyone of a couple of things. So first, this session is being recorded, and we will follow up in a few days with the recording and the slides for your viewing reference afterwards. And then, as the presentation goes along and you have questions or comments, please feel free to use the chat function, and we'll be sure to bring all your questions or comments back up during our Q&A towards the end of the session. The third one is that once the speaker gets on and presents, please do make sure that your mic is muted so we don't get any feedback or echo along the way. And lastly, again, if you have a topic or a question in mind that you think Peers would be a great platform for, let us know. We're happy to collaborate with you. All right, so now I am handing it off to Julian.
Hi, good afternoon, or good morning or evening, depending on where you are calling in from around the world. Thank you so very much for joining us today. My name is Francis Julian Lantry. I'm a research project manager here at the Center for Global Health Engagement, primarily tasked to work on the Global Health Engagement Research Initiative, which is a funding program conducted by or administered by the Center for Global Health Engagement. I've been with CGHE for over 6 years at this time, and have been working on the GHERI program throughout that. And today's research project is primarily through the GHERI. It's very much an honor to be joined and to be able to join the knowledge management team here at the Center for today's Peers session. So without further ado, I'll start by discussing a little bit about the GHERI program, which was the funding mechanism by which Dr. Stigler Granados' study was conducted. And I'll open that with our sort of classic disclaimer that none of my views are necessarily tied to the DoD or to the center. The Global Health Engagement Research Initiative is an annual Global Health Engagement research funding program that's administered by the Center for Global Health Engagement. We collaborate with a broad variety of different institutions and organizations, whether it's the Uniformed Services University, DoD labs, the combatant commands, the Assistant Secretary of Health for Health Affairs, Defense Health Agency, Office of the Joint Staff Surgeon, the list goes on. And the primary purpose of the GHERI is to fund research programs in support of the GHE research priorities of the combatant commands. Today's study is another one of those examples. And in our role as the administering entity of the GHERI, CGHE serves as a link between all those different entities. The executive board is comprised of members of Health Affairs, the Defense Health Agency, and the Office of the Joint Staff Surgeon. And we work closely with the geographic and 2 functional combatant commands to understand and identify the GHE research priorities within those areas. The ultimate goal of the GHERI is to serve as a funding and facilitation mechanism intended to enable global health engagement research pursuant to the needs of the unified combatant commands. Today's Peers discussion will focus on the findings and implications of a GHE-related research study conducted by Dr. Paula Stigler Granados in collaboration with teams at San Diego State University and Texas State University. Dr. Stigler Granados is the Associate Professor and Division Head of the Division of Environmental Health and of the College of Health and Human Services at the San Diego State University School of Public Health. Her background in environmental health services and global health, as well as her expertise in the study of Chagas disease, water quality, global health, public health policy, environmental health, and neglected tropical diseases, prepared her very well for a GHERI grant in support of Northcom's GHE research priority, which focused on diseases of the Southwest U.S. border points of entry. Before we get started, we'll conduct a very brief survey, should only take about a minute or two, regarding the audience knowledge related to Chagas disease. And if we could advance to the slide related to the poll, we will go ahead and get that started. We have a link that's contained on the next slide, as well as a QR code with 3 very short questions related to your knowledge of Chagas disease. So we'll give you about a minute or two before we get started with the, before we hand it over to Dr. Stigler Granados and get started with the presentation. Please go ahead and use the link or the QR code on the screen in front of you to access this poll.
We've also shared the link on the chat if you prefer to do it that way.
Okay, so we will. I will go ahead and hand it off here to Dr. Stigler Granados. Ma'am, thank you very much for your time and for being able to join us today. The research that you've conducted in collaboration with your research team and collaborators will definitely, I think, be very educational for folks here with regard to the impact that Chagas disease can have on GHE activities and how those implications draw out to the broader GHE enterprise and landscape. Without further ado, please take it away.
All right, thank you so much, Julian. I'm really honored to be here today. I wanted to just acknowledge, I also see quite a few friends and colleagues on today, so thank you all for being here. I also want to acknowledge my partners on this. I have had a great team of people to work with at the U.S. Army Public Health Command in San Antonio, as well as out here in San Diego at NEP-MU5, and then my colleagues at Texas State and here at San Diego State as well. And so I see that we're still taking the poll. It looks like many of you have not come across Chagas disease in your personal and professional life, but some of you have. And so I'm assuming that this is probably taking many different types of forms. It could be that maybe you work with the bugs, or you work with animals, or you work with humans. So, and then a couple of people just not sure, and that makes a lot of sense too. So maybe, let's see, here we go. Do you think you could have been exposed to Chagas disease? So about half of you know, but a good 32% said yes. And some of you who are, I've seen your names that you're on right now, I can imagine why. And then several of you are unsure, and that's actually a really good response as well. Being unsure is probably how most people feel, because you may not know if you've been exposed or not. Great. Was there another question, or was that? Oh, here we go. And lastly, so is Chagas disease something you feel the military should be concerned about? I see that 44% said very concerned, 46 moderately, and then a few are kind of neither nor, and then a few slightly. So that's a really also expected response. I'm glad to see that several people are at least seeing that it's moderately to be of concern for. And maybe at the end of this presentation, you'll have different opinions about how you feel, whether we should or shouldn't be more or less concerned about Chagas disease amongst our military. Great, thank you. We can go ahead and go on to the first slide of the presentation. There we go. Okay, so I'm going to just talk again about Chagas disease. This is something I've been working on for about the last decade now. And again, as Julian had mentioned, we had a DoD funded project through GHERI initiative. It's been really great working with people to better understand what role does Chagas play in our military, with our military, how is it being surveyed in terms of the animals, the humans, and the vectors. Next slide. So I don't have any conflicts or anything to disclose. Next slide. And then the objectives today, and I think Julian mentioned a few already, but really just talking about this link between the Chagas disease surveillance and forest health protection, which would be really important to understand that link. Learning about some of the implications of surveillance research for this inter-entity collaboration. And then understanding opportunities for those partner nation engagements, which is really important. And then looking at the impact Chagas disease just has on global health overall, and how, if we understand it better, the surveillance with ourselves and with partner nations can help practitioners to enhance disease management. Next slide. So I'm not going to spend a whole lot of time really talking about what is Chagas disease, but in general, I think we already asked the question, have you ever heard of it? Most of you had. If you're here, you've probably at least heard of it. We often ask that question, do you live in an endemic area for Chagas disease? Well, the response is if you live in the United States, not all of you are in the United States right now, but if you are in the United States and you live in any of these states that are highlighted in purple, then you have the possibility of encountering the vector in your life, because we do have the vectors that are capable of carrying the parasite that causes Chagas disease in each of these states. I think Nebraska was the last one that was just added. So we now have about 30 states where triatamines that carry the parasite live. And so are we endemic or are we not endemic? Well, the definition of endemic is that more people are infected with the disease from the vector than the disease is imported. And at this point in the United States, based off of a couple of reasons, one, the lack of surveillance, and two, maybe the types of triatamine vectors that we have are not necessarily living inside people's homes as much as they do in endemic areas of Latin America. We will also see that we are endemic, not endemic. And so we don't have more transmission by the vectors here than we do have imported in transmission in the United States. However, because of the lack of surveillance, it's really difficult to also grasp whether we should be endemic or not. So this is always a question of, we're one of those places where we have the potential to be endemic, but we're not quite there yet. Next slide. So this is just a map kind of showing the different species that are of concern that we have. I had a wonderful grad student help make this map, and you can see that Texas is a very special place where we have multiple species living in the same place, of which the Gersteckeri and sanguisuga are two of the bigger ones of concern. As we've started to see them moving closer and closer to being like domesticated or peri-domesticated, kind of enjoying feeding on animals that like pets and things that look closer to humans. And so we're watching all of these species of concern across the US, and just taking note that we are trying to survey these, but we still have a long ways to go in terms of understanding their habitats and what they like to feed on, and how disease transmission amongst these different species works. Next slide. So basically, the global impact of Chagas disease it's very common in some parts of Mexico, Central America, and South America. About 8 million people. This is probably a gross underestimate of people are infected, though. We think about 20% of the population could be at risk in these endemic areas. Causes on average about 12,500 deaths. Again, an underestimate because we're not necessarily tracking the disease very well, but this is a modeled estimate. And over $6 million in global healthcare costs that we know of. Undiagnosed Chagas disease that presents as cardiovascular disease is a huge cost, but it's completely unrecognized and under, I guess, studied at this point. Next slide. It is named after Brazilian physician Carlos Chagas in 1909 when that happened. Again, it's transmitted by a triatamine vector, which I'll sometimes refer to as either a triatamine or a kissing bug. It's the same thing. It's what we call the name here in the United States. The parasite that causes it, you can see here on this slide, is Trypanosoma cruzi. Sometimes we call it T. cruzi for short. And as I stated earlier, it is endemic in the Americas. It is not endemic outside of the Americas. And so cases that we find outside of the Americas are almost always imported cases. Next slide. So it is considered to be a neglected disease. Sometimes people call it a neglected tropical disease. I'm sort of taking the tropical out of this because some of the deserts in Arizona don't seem so tropical, but we have quite a few kissing bugs there. So it is a disease of emerging importance. The DoD has recognized that as Julian was saying, through even funding through the GHERI initiative to try to understand how important is it within, especially amongst our military populations. It is associated with congenital transmission, so mother to fetus, and somewhere between 1 to 5% of pregnant moms can pass it on to their fetus. It can be bloodborne and through organ transplantation, especially in non-endemic countries. These are things we're concerned about mostly as contaminated blood supplies, organ transplantations, and that congenital transmission. We estimate, I always say this is really probably a gross underestimate. Approximately 300 individuals are estimated to have infection of Chagas disease in the United States. This is modeled off of the number of people coming from endemic regions of Latin America and the prevalence that we know of in those countries. It does not include local transmission, and obviously, since we're understudying this here, it's also being undersurveyed in other countries, and so the prevalence rates there are not actually well known either. So 300,000 is an estimate, but some people have estimated it to be much higher than this. Next slide. And as I mentioned, it's a vector-borne disease. It has many animal reservoirs. We'll talk a little bit about our military working dogs, but definitely dogs have Chagas disease as well. Again, congenital, oral. We don't talk about the oral transmission very much because it can be transmitted if, for example, like some of the South American kissing bug species like to live in the trees and will sometimes drop down into food supplies, or we've had cases of foodborne outbreaks where the bugs have gotten ground up into fresh juices. And so it is possible to have oral transmission. Mostly we talk about this with our canines, as dogs and other animals will tend to eat bugs. And if they do eat an infected bug, they will indeed also become infected. It's quite transmissible through the gut. So this is something we talk about mostly when we talk about animals. Next slide. Oh, I guess I should have mentioned the most common way people get it is through contact with the feces of an infected triatomine. So if the kissing bug is indeed infected, it can transmit the parasite whenever it takes a blood meal, it defecates, the parasite is in the feces, and that is how, if the feces gets into a cut in the skin or the bite wound or any eye or nose or mouth areas, the person or animal will become infected. So again, the acute phase of Chagas disease is that first 6 to 8 weeks, and oftentimes people have no symptoms, but once they become infected, they might have a mild fever, mild flu-like symptoms. It's rare that we actually catch this during the acute phase. And after that 8 weeks, that's when it advances into the chronic phase. We have two forms of chronic. We have indeterminate, which is with no signs or symptoms whatsoever, and people can stay there for a lifetime. Or 20 to 40% of people will eventually, over some years or decades, progress on to the determinate form, which generally ends up as Chagas cardiomyopathy, so enlarged heart or enlarged gastrointestinal symptoms, such as like enlarged colon or other parts of the gastrointestinal system. It can reactivate if people become immunosuppressed. And so there have been times where we have seen people undergo immunosuppression therapy and become Chagas positive, symptomatic in the determinate form. And so this is something we have to think about with some of our patients that are at higher risk for immunocompromised becoming Chagas activated. Next slide. So I could spend all day talking about diagnostics and treatment, and I'm happy to talk offline with people, but the basics of it is that diagnostics are a bit complicated. However, you generally need 2 separate tests to confirm a diagnosis. CDC will provide confirmation. However, this has to go through the health department. Even our military partners do this as well. We have quite a few cases in Texas that I know of where they will maybe test positive on a blood donation, then they'll get a lab test done through the hospital or the clinic that will also see a positive second test, and then the blood sample would be sent on to the CDC to confirm if it is indeed a positive or not. If eligible, the person can be treated with anti-parasitic medications. We have benzimidazole and mifrodamox that are now available, and they're FDA approved. That happened around 2018. They are approved for children, and so they have to be used off-label for adults. And eligibility basically requires that they have not had advanced stages of the disease. They're generally under the age of 50 and relatively healthy. And so it's a case-by-case basis to determine whether a patient should be treated or not, but we almost always recommend treatment to those that are not in the symptomatic form, are under the age of 50, especially children, and anyone that is healthy enough to take the medication we would recommend treatment for. Next slide. So variety of tridamine species in the Americas. This is just a map to show you how many different types of species we have, but this is just a short list. We have about 135 different species. And the reason why I bring this up is because I think it's really important for surveillance as clinicians or as public health professionals or veterinarians, anybody basically. If somebody comes to you and said that they found this bug in their bed or they think they've been bitten, it's good to know the different types of species that are in the area where you are to help people understand if local transmission might be happening. Next slide. There are 11, I think, species. I have to count again. It's either 10 or 11 species of triatamines in the United States. Again, if you're in Texas, we really think about that Gersteckeri and sanguisuga. I'm out here in San Diego right now. And we have the Triatoma protracta, which I'm not a huge fan of because they're a little bit more difficult for me to identify. But you can see they relatively look kind of the same, but a little bit different each one. Each one of them has different feeding patterns. All of these so far that we know of are capable of transmitting the parasite. Some of them, again, prefer more domestic locations and others are more sylvatic. Next slide. I drew this map. It's really crude, but I thought I would just kind of show you where some of the U.S. military installations are in states that do have known triatamine activity. And you can see it's quite a few because, again, those lower 30 states, again, please don't judge me on my poor line that I drew across this map. It was in a hurry. But basically, we have quite a few installations where there should be having active surveillance being done. And on top of that, the health clinics and providers there should also be aware of the different, of Chagas disease and the different types of potential transmission that there exists. And this does not show a map of all of our Latin American installations as well, which are also in areas with known triatamine activity. Next slide. So in the United States, as I've kind of alluded to already, it's an emerging concern, especially in some of the southern states where we know local triatamine bugs do have T. cruzi. We're seeing upwards of 50 to 60% of the triatamines are infected with the parasite. Most of these studies are coming out of Texas. Thankfully, I think a lot of our U.S. Army Public Health Command folks, I know who are on the call right now, have done a lot of this research. And so thanks to them, they're bringing this to our attention. We also have quite a few colleagues at like Texas A&M and other places that are showing that it's a pretty high prevalence of the parasite within these triatamines. And so this really is prompting a need for increased awareness and preventative measures, not just for local transmission, but also we have a lot of people living here in the United States that have come from highly endemic regions as well. One significant risk within like the United States context is, as I mentioned earlier, congenital transmission. So as this disease can be passed from mother to child, it's really relevant among especially, say, immigrants from Latin American countries, first gen or second gen moms coming over. They could be passing the disease on to their child. And if the mom is not tested, then the child would not know they also might be infected. And that person would then, again, be infected at a young age and carry it further out into their life. So the chances of them becoming activated or into the determinate form could be higher, just as a result of them having the disease for longer. And so there's a public health recommendations right now that myself and several of our colleagues are coming out with, is this importance of routine screenings, especially for pregnant women. and to detect and manage the disease early. And so I know I've been pushing quite a bit right now for screenings in pregnant women across the southern United States, or anywhere actually where we have populations of women who are from Latin America. Or we've even seen second gen pass this on. It could go from grandma to mom to child. And so we recommend anyone that has a mother that was born in Latin America to get tested, but especially if you're pregnant, it's a good time to get tested. And then also just sort of to further mitigate the spread, or more people becoming and being infected and not knowing it, we have a lot of outreach and education efforts, and this is really essential. Health departments we work really closely with, they're encouraged to engage with any at-risk communities or promote awareness and improve accessibility to these screening resources. It's a challenge right now, though, because not a lot of people know about the disease, and there's other priorities that are out there. So this is important to try to keep this disease under control domestically, but also amongst our military population. This is important too, to conduct screenings where necessary. Next slide. So really what makes it neglected in the US is it's just received not a whole lot of attention from the US health system. It's mostly believed to be a disease of Latin America. So it has in the past been said that it's not clinically relevant in the United States, but we're acknowledging now a little bit more frequently through sessions like this and others that it is actually something that we should be thinking about. It's often considered to be a disease of poverty, but as several people, even on this call, have noted, in certain areas, especially in rural areas, you can find these bugs in million-dollar homes. It's not unlikely that other people couldn't be impacted. And again, if it's congenital, being passed from mom to baby, it doesn't necessarily mean that somebody who lives in poverty is the only people that are going to be infected. Limited healthcare amongst the groups that generally do, we find a higher prevalence rate of the disease. And then again, we just don't understand the disease burden or prevalence in the United States at this time. Next slide. This is a kind of a chart that I put together for a paper that I wrote about understanding these gaps in our system and what are some of those actions needed to strengthen health systems to scale up diagnosis and treatment of Chagas disease. This is relevant for the general civilian population and for the military population. You can see a list of the barriers like limited knowledge, few providers offering treatment, the low provider awareness. I think if you can hit the click button, the red box will pop up here. If you could advance the slide, it should. There you go. Then we also have that low provider awareness, which some of what we're doing today right here through this peers communication is increasing that education and helping providers or others understand what are the protocols for helping people to understand a little bit more about this disease. And then the absence of screening programs. This is important because at this time, we are screening blood donations, but that's in the civilian population for first-time blood donors. If I understand correctly, I've learned that I believe that all blood donations given through the military are screened. If anybody wants to correct me on that in the chat, please feel free. But I think that's what I learned most recently. But what happens after that is the bigger question. If somebody tests positive on a blood test, what happens after that? And is that person getting the effective diagnostics that they need and then access to treatment? Next slide. I think it's another circle is going to pop up and then we can go to the next slide. Thanks. So in terms of global surveillance of Chagas disease, because we're here talking about, global health, really, this is something that's really critical. Early detection is sometimes the only means of really helping to control this disease, because once it becomes symptomatic, people are untreatable and it's often fatal. Excuse me. Excuse me. So it's really important to screen people while they're in that asymptomatic phase of the disease. This is especially, in all areas, but in these non-endemic areas where we're not really thinking about Chagas disease, again, it could be going undiagnosed. So it's quite important for us to start these screening programs and early detection. So it's challenging in sometimes in like endemic areas, like in Latin America, where healthcare systems don't always have the either the familiarity with the disease or the resources to be able to address it. And so delayed diagnosis is more common there, which means more death, unfortunately. So this undiagnosed or untreated really kind of heightens that risk of complications. And so in the non-endemic areas, we have global migration as this key factor, and cases now being identified far beyond Latin America in places like the United States and Spain and Japan. We have quite a few immigrant populations that come there, and the non-endemic countries are also dealing with this lack of provider awareness, lack of understanding the diagnostics and treatment protocols. And so this is why it's really important in these non-endemic countries to make sure that surveillance for the disease is there, including like blood donor screening, community awareness programs amongst high-risk populations, and then looking at even like travelers coming from endemic areas as well. And then for the methods, by focusing on what we in the United States can do is like integrated pest management and building public health infrastructure here, and also in other countries where it is endemic. This can help get things under better control. I have to say, there's some places in Latin America, despite not having as many resources, they have done decent jobs at outreach and education, and some integrated pest management and spraying campaigns and things to try to bring the level of prevalence down of the disease. But again, with limited resources, it's quite difficult. And so I think collaboration and shared strategies are really important to keeping Chagas disease in check. And that also means us learning and collaborating from our partners in endemic regions that have more experience, and then also supporting them with the resources that they might need in order to help address the disease. Next slide. So I just kind of was brainstorming and put together what I thought were some challenges in terms of surveillance and engagement. And I've touched on a few of these, but just to kind of spell them out and dive in a little bit deeper on these. Obviously, that limited awareness and resources is a huge key piece. And this is what a lot of the work I've done for the last almost decade is just on raising awareness. That in and of itself is helping to sort of move the needle a little bit on what needs to be done. But it still remains neglected in many countries, and there's just not a whole lot of funding to deal with it. So not just for research, that's a whole other story of developing vaccines and other pieces and to help address the disease and better treatments, but really just there's not a whole lot of attention from public health systems about this disease. And so awareness raising is key here. And then convincing policymakers. So sometimes efforts to like prioritize Chagas can have a lot of barriers because of the low visibility and that lack of perceived urgency. It's really difficult to get people to think, oh, I should implement a screening program, or oh, maybe we should be screening our pregnant moms or our newborns for this disease, especially in these areas where we may have issues. I see something in the chat, and I guess I can come back to that in a minute. It just popped up about strategies. Actually, let me just look real quick if I can. Oh, here we go. Julian, should I answer these now or should I wait?
Our recommendation is that we pick that up during the discussion phase in approximately 10 minutes.
Perfect, thank you. And I needed the time check, so thank you.
Sure thing.
Great. All right, thank you all. And I'll try my best to answer those questions in a minute. So infrastructure barriers, obviously affected regions don't have adequate healthcare infrastructure, especially in those endemic places. And so it's making monitoring difficult, surveillance is difficult. Something I spend some time thinking about quite a bit is the stigma and misconceptions. And I think because of that low awareness and misconceptions, it can hinder that early detection and some community support, again, because people often think of it as a disease of poverty. I know spending some time in El Salvador, talking with a lot of the community women about Chagas disease, and it was often interesting that the women would say, no, I've never heard of it, or I've never seen those bugs, or I don't know anything about it. And then I would talk with the men and they're like, oh yeah, we've got them everywhere. And I kept thinking, what is this discrepancy? And then I realized it's this stigma about this disease in Latin America and other places. And again, just the low awareness. And some of the other misconceptions I think that I hear a lot from providers, especially like clinicians and stuff, is like, oh, we don't have that here. That only lives in those thatched roof houses and mud houses. And that's just not something we have here in the United States. And so local transmission is almost completely off their radar sometimes. And so just kind of breaking those misconceptions of trying to help people understand that anybody living in an area where they have endemicity of this triadenine vector, that it's possible that they've been exposed. And so it's probably less likely in the United States, but it's not impossible, especially if they've been in regions like the border regions, in the colonias and other places where, especially in rural areas, or training in places like in this photo, where you may have encountered it and not even know it. And then the limited diagnostic tools, it's diagnostics are tricky, and that lack of accessible low-cost diagnostic options, especially in rural areas across the, Latin America and even in the rural US, makes it a little bit difficult. Next slide. I've got a few more here. Vector adaptability, which I touched on, and I think Walter's on. I hope he doesn't mind I use some of his photos here. But the bugs have the potential to spread due to climate change. They could be moving north, or if they like warm climates. And so as things do warm up, not only could they move in location, but they could also extend their seasonality. So lucky people in San Antonio, where I lived for a really long time, kissing bugs are pretty much there year round. But as you move up into, say, like northern Texas, maybe they slow down during the colder seasons. As you know, it can get kind of cold in certain parts of Texas. But if you have longer, hotter seasons, you're going to have longer, hotter seasons for kissing bugs to become active. We also have economic constraints, so limited resources, restricting that public health investment, especially in those high burden rural areas. Cross-border coordination. So, understanding immigration, how that works. I've been working some with some of the migrant groups and the refugee organizations, asking if people coming from Latin America, we could go ahead and screen them upon entry. That way we can connect them to care, especially if they're pregnant or a woman of childbearing age, so we can prevent that disease in the future. So, and I like to bring up that too, because we've even had a few cases I've seen presented at conferences about people who have migrated maybe from Asia or China, come through Latin America, up through the Panama and all the way up into Mexico, and they have come across and tested positive. And so even on the migratory pathway of people coming from non-endemic countries, but coming through endemic countries, that's another place for transmission to occur. And then training gaps, just a lack of training in our regions like here and other places that are non-endemic, can help lead to misdiagnosis and treatment delays as well. Next slide. All right, so military and Chagas disease, personnel that are stationed in endemic areas can face heightened exposure to Chagas disease. Oftentimes this contact with the triadenine bugs or the other environmental factors that can be common in these regions. And upon returning from those areas, I believe firmly that they should be targeted for screening and monitoring to help manage any potential infections, which means that we need trained clinicians due to that need to time of proper testing. So once a person's been exposed, we generally have to have them wait 6 to 8 weeks post-exposure to be able to take the hemogen-based tests, because they need to have built up the antibodies. And so there's a timing element to this. Also, in addition to screening, there's a lot of military research programs that could contribute valuable data, like this one has, through the surveillance data that we've been collecting, especially, again, if you're collecting maybe data in Honduras or other places in Latin America, just conducting studies on disease progression or environmental vectors. I believe firmly that the military research can help support that broader public health efforts and inform prevention strategies. And so collaborative partnerships between our military health programs and local agencies can truly help extend the reach of surveillance and vector control efforts. I know, again, U.S. Army Public Health Command has some incredibly trained entomologists and others out there who have this training to go out and help support people with this integrated pest management, and looking how we can just strengthen each other's capacity building in affected areas. Our Army Public Health Command people came out to San Diego, to California and Arizona to help train our Navy personnel from the PrevMed unit over here in bug collection. That's great crossover trainings to help each other try to understand how are people being impacted, etc. Next slide.
Ma'am, I hope you don't mind my interjecting just to say I know we've got a lot of really great questions in the chat here. And I wanted to also share that we have about 20 minutes after the close of the lecture, which will be in 40 minutes time, or sorry, the close of the lecture is in 20 minutes and then 20 minutes beyond there to answer some of those questions. For the presentation phase, I'd say we have about 5 minutes left, if that's okay. Thank you.
That's perfect. Thank you. Keeping me on track. I'll go through these next pieces pretty quickly. So global health partnerships, I think, as we mentioned, it's really essential for managing Chagas disease. These collaborations really rely heavily on that mutual respect and transparency. So I think for interoperability, it's really important to have these partnerships engaging based on these values. And I just have to say, like, this is something we're working towards right now, is just understanding how can we work better with our partners in these endemic regions. And so also, again, long-term partnerships hopefully will help strengthen these collective response, because this is something we really need to work on more. Next slide. I always like to emphasize this as a One Health approach to Chagas disease. As I mentioned, it's the human, it's the animal, it's the environmental health. All of this is really important, that all of these sectors talk to each other. So I want to bring up, for example, the military working dogs, which is actually how I got involved with this process in the first place, was at Lackland Air Force Base, where the working dogs are housed. We noticed there was a problem with Chagas disease in the working dogs. And so they contacted us at the School of Public Health in San Antonio and said, hey, how can we link this to the human connection? And I started working on a CDC grant to help raise education and awareness about the disease, which started a task force and really got this whole program connecting all of these pieces together. There was lots of people already working on Chagas disease in these different sectors, and it was important to sort of bring everybody together into one place to start talking about all of our efforts. And as I'll mention in a second, basically, like, for example, understanding if people's dogs are testing positive, what does that mean for them? And how can the veterinarian translate that into human health potential? And so I think that it's important for veterinarians to be able to tell their clients, the owners of the animals, hey, you should consider testing yourself, because if your dog is tested positive, you most likely have the vector living in or around your house. Next slide. And so this is kind of sort of where I start to wrap it up a little bit, but policy and economic recommendations. Obviously, increased funding for Chagas screening and awareness to protect the military is really important. Also, understanding how it can be cost effective to screen, especially it's more effective to screen and treat early than it is to have to manage the disease in the end. And then obviously increasing that screening for higher risk populations. And this could provide life-saving benefits for our soldiers and servicemen and women. Next slide. So I'll just quickly mention the unique role of the military in Chagas disease is addressing those research gaps. Looking at high-risk deployments and understanding, if people are in these high-risk deployments, and that doesn't just necessarily mean in Latin America, it could be in the southern United States. Are we screening them? Are we making sure that they're not being exposed? And it'd be a great research to be able to go out and actually see when people are being exposed, and if they are, what happened and how can we prevent that in the future. And so definitely having resources allocated to this, we have to prioritize it and put those policies into place so that we can actually make sure that that vector control and disease management is happening. Next slide. And then next slide, I promise I'm at the very end. These go really quickly. Just developing some educational materials. We have put some out there. We're working on actually creating even more that have that One Health approach, where we can actually provide this for the veterinarians, for the public health people, for the physicians, etc. And this is military focused and civilian focused. Next slide. This is just another little example of coming up with education on awareness potentials. Next slide. And then something that one of my amazing colleagues at Texas State, Dr. Betancourt, and I one day on a whiteboard came up with is like, how do we get this message to the healthcare providers? And we realized the One Health approach right there through veterinarians and pest management professionals, the entomologists, public health agencies, etc. Everybody's sort of working together, because it's ultimately our healthcare providers for our humans and our veterinarians for our animals that can actually make these diagnoses to help us better understand prevalence. Next slide. And then a lot of people, I always put this in because it's important. People say, who do we screen for Chagas disease? And I've mentioned it already, but just to kind of conclude with this, but basically any first gen or second gen people coming from Latin America, we recommend screening. Anybody who's lived in Latin America for more than 6 months, we recommend screening. Newborns or children of seropositive women, any family members of people that have tested positive, like if we test a mom, she tests positive, we'll test their babies, their children, and we'll often find aunts, uncles, cousins, or other family members that are also infected. And then there's more on this list, but basically we have questions around people with Chagas positive dogs. Should we? I'm going to say yes if you live in an area that has quite a bit of activity with triatamines. And then service members deployed to areas with known triatamine activity, absolutely. But again, saying that's the last bottom 30 part of the United States, we have to use discretion about what does that actually look like and where were they deployed. Next slide. So I think this is right at my conclusion right here, but basically, mostly what we know about Chagas disease is a proxy to our civilian counterparts. So we really do need to understand how this disease is affecting our active duty service members and our veterans as well to help mitigate that impact on performance outcomes. And with our military working dogs, they are especially at high risk. I'm 100% certain the people out at the Lackland Air Force Base know this, but we also need to think about, for example, out here, maybe like in San Diego, for example, any of our dogs that are out here that maybe they screened negative in Texas, but they got transferred over to California, to some of Arizona. We need to continue to screen them. I'm still trying to figure out what the protocol is for the dogs, but I think continued annual screening for them is really important because they are at really high risk considering they sleep outdoors and they eat bugs. Next slide. So high mobility of US troops to these different regions in the world make this surveillance, screenings, and diagnostics extremely important. And we have to be able to produce like these educational programs for everyone, leadership, clinicians, service members, and everyone to help make sure we build that awareness and can help control this disease in our civilian populations and our military population. And I believe the next slide just acknowledges so many of our amazing partners. And then the slide after that is just my contact information. So happy to take questions. Or Julian, you can tell me how this is going to work.
Hi, ma'am. Thank you so much. That was a really fantastic presentation on work that we understand has been very valuable, not only to the Global Health Engagement Research Initiative, but as we can see here, a lot of information and conclusions about your work with Chagas disease that I think are really relevant for modern global health engagements, particularly within that AOR. I know there's a lot of questions in the chat, and I'm hoping that we can get to as many of them as possible in one way or another. Just as a reminder, Dr. Stigler Granados has generously volunteered about 20 minutes of time after the hour, so we'll probably be going over questions up until that point to make sure that we've covered all of your really fantastic questions. And I want to start by talking about one of the questions that I saw earlier in the chat here, which is about the rate of states that are reporting Chagas disease. I think that we saw how far Chagas disease has sort of started to spread into the continental United States. It's a little. There are a couple of other questions about rate with regard to how quickly those states are demonstrating endemicity, or whether in fact the rates of prominence and prevalence are increasing, within those lower states. So if you don't mind speaking a little bit to that rate in those new states.
Yeah, so surveillance is increasing just, I think, as we're building awareness. And I think this has a lot in part to do with the investment of like your program and like the CDC's educational program that we have with these cooperative agreements with them to raise awareness. We only have 6, maybe 7 states where it's reportable. I always lose count because some drop in and some turn on, and I just sometimes don't know. Texas being one of them, the biggest state. I'm working real hard on California right now. It's only reportable in Los Angeles and most recently in San Diego because we had a lot of conversations with people about that. But I think when there's not reporting of the disease, it makes it really difficult to actually do surveillance. And so I think that that's something we're working on. There's a bigger play going on right now where we've just finally gotten the case definition for Chagas disease across the United States to be approved to this state and epidemiological association, a group of people. And so now that we have a case definition, we're actually hoping more states will make it reportable. And so reporting the disease is one thing, doing the entomological surveillance is another. I believe there's a complete lack of the entomological surveillance. That's a big gap that we have in our country. And in terms of the disease, it is creeping along, and more people become aware, more people are, and again, the changes in the, like, for example, benznidazole and nifurtimox are now available. We now have one diagnostic test that has been imported now into the US that's a little bit better than previous ones. And so we have a little more confidence in our testing. So all of these little factors together are increasing people's awareness and increasing the testing. But the rate of states reporting diseases increased largely, not really, but it is slight, I should say.
Sure. Yeah. Thank you. That's a great insight into what we're looking at in terms of how quickly the screening is rolling out or being evaluated. And I know we talked a little bit about the screening process with regard to how the conditions which end up triggering a screen for Chagas disease. I saw there's also a question in the chat about screening during blood donations, and I'm curious to know if you have any thoughts about not only that, but whether the screening process is potentially accessible enough to be scaled in a way that could be practical for epidemiology.
I think it could be practical within the military, but outside in civilian, I think it depends, because if you think about it, a lot of the population at highest risks in the civilian world are probably accessing our federally qualified health centers, which in some states are really, really underfunded. And so in those situations, I think that it's difficult to pay for these diagnostics that are complicated, require 2 tests. It's kind of can be expensive. There is some FDA approved rapid testing right now, but it's not where we need it to be for the United States. It might work well in Latin America. This is complicated by the genotypes of the parasites that we have in like central Mexico and the US. It doesn't work as well with some of our diagnostics. And so I think that in the military, it's quite feasible to bring in. I mean, I've been a supporter of the idea of screen everyone that comes in. I think that that's a valuable tool, as we screen for a lot of other things that are way less prevalent. And so my thoughts are, if we do know that this is happening across those 30 states within the United States, and then we could prioritize in the military who we screen. It could be people that have experience living in those lower 30 states, or they come from Latin America, or they're first gen, that we would screen them. But it is feasible. It's a bit complicated. Blood donations is tricky because we do not use blood donations as a diagnostic form at all. Mostly because a lot of our blood donation diagnostics are quite sensitive, but not quite as specific. And so they're going to be picking up a lot of false positives. And so we can't rely on that as a diagnostic tool. This is hence why we need multiple tests. But I do think if the military were to, this is another really great place to engage in this type of research and surveillance, is to have the military start screening their population. And if that happened, we'd really understand the prevalence in the United States rather quickly, and then have better protocols on what we should and shouldn't be doing.
Perfect. Thank you. I really appreciate that answer, because I think it speaks well to what is reasonable within that realm of screening. I hope you don't mind if I jump around a little bit in the chat just to try to hit as many questions as I think we can during the time that we have. I saw a really interesting question about the best strategy that was used to increase the awareness of Chagas disease in South or Latin America. Would you mind speaking to that strategy?
I think a lot of their strategy is on the ground education campaigns. And so having lived there for a while, I've seen like giant billboards, or they use often sort of like this uniform type of graffiti on the brick walls and things there, or you know what I'm talking about, like they'll paint messages on things like, have you seen the bug, or talk with your doctor. So I really think in Latin America, they have on the ground push for managing the campaign to help people to become more aware. And they've also used these mass sort of spraying campaigns where they've sprayed pesticides out there to sort of kill off the bugs. I've seen them use like plastering programs to help some of the houses that had cracks, to help plaster them, to help reduce their spread. So lots of really just sort of on the ground, you know, activity, as opposed to the US, where we're trying to work from the top down, because if people our civilians or others know about the disease, they often hit this barrier with their physician where they're like, oh, we don't have that here. So we're trying to like, okay, well, let's educate the providers first, and then we'll go at the population. So I think general population education has been really helpful for them. But again, it takes a whole lot of effort on their part to help with those campaigns, but that's their strategy generally.
Of course, yeah, and you know, understanding how to get the message out to specific audiences, I think is a science that is practiced, but something that is always developing.
Yeah, and providers in Latin America tend to know about it. So it's our providers in the US, they just don't know about some of these diseases that have been typically thought of as not being here.
Of course, yeah, yeah. I understand also that there's a raised hand in the audience from Mr. John Keed. If you wouldn't mind, please go ahead. Mr. Jungi, can you hear me okay? You're welcome to go ahead and ask your question with your raised hand there.
Hello, I did it by mistake, sorry.
Okay, understood, no problem. Okay, so I'm going to go ahead and jump back to the chat here. And I have I understand that we had multiple entomologists who were able to join today, which I'm very glad to see. Thank you so very much for joining and contributing your expertise here. Dr. Stigler Granados, I know that we have also talked a little bit in the slide set about the testing for pets and how your efforts have been maybe trying to bring that a little bit more into alignment. And I know that you've also been talking a little bit about Chagas disease as it's impacted by and affected by One Health. I know the question here is about whether testing in pets is being done regularly, but I also want to get into a little bit of how intensive that testing is. And, you know, I'm once again coming back to that question of, you know, with regard to that intensity, how practical it is to scale testing for pets.
Yeah, that's a really great question. It's something I'm exploring more right now, actually, with several of my doctoral students, because currently, it's not a routine screening. Texas, it's actually becoming quite a bit more. Quite a few veterinarian colleagues. I've got some of my students and veterinarian colleagues on the call here too. But like currently, if you want to screen your dog, for example, there's one test that has to go through the Texas Department of Veterinary Medicine laboratories. And it's not cheap. I've heard it's a couple $100, and there's no real treatment for dogs right now. There's some clinical trials out there. There's a couple of combo drugs that people are using. And so sometimes it's difficult to screen the dogs because if there's no treatment for them, it's sort of, you know, how do we know? So I think like our military working dogs in Lackland, I know are getting screened annually. So I've heard. I think that's what the case is there. So that's something that they're doing. They can do it in-house, but I think they send out most of the testing. So is it feasible? Not very much, but we're looking at kennels and like breeding operations. They're really concerned about this, or some of those like guide dog locations. I worked with some of the dog facilities for blind people that they train their dogs there. Very, very important for them. So we are recommending regular screening, especially for the pregnant dogs, because again, we'll have a whole litter of pups that might pass because of congenital transmission. They are potentially more likely to pass congenitally. I think if anybody wants to correct me on that, but I've seen it more frequently with the dogs. Another quick example is I have a couple of students, Major Kerwin, who I think is on with me right now. She's active duty, but also doing her MPH with me out here in San Diego. And we're looking at shelter dogs here in San Diego County. First pilot study we did showed a 38% prevalence of the dogs in the shelters. So I think that's something, it's a little smiley, the face there pop up, but it's, Yeah, Texas probably even has a higher rate. I think Dr. Sarah Hamer's done some studies there showing up to 50% prevalence in some of the shelter dogs out there. So I think we have a lot of work to do. I think dogs can serve as a really good sort of indicator of local transmission and what that potential is. So, but it's not great. It's not great testing techniques right now. I'm using a Chagas StatPack rapid test for research on our dogs, and so far that's been pretty good, but we have to confirm it with IFA or other ELISA testing, and it's complicated. I would love more people to test their pets, obviously, but I would probably really like for more people to test themselves if they do test their pets and their pets test positive. That's probably my goal as well. Oh, you're muted, or I can't hear you.
Thank you. I'm going to call that the last question that we have here during this lecture session. I'm going to pass it over to my colleague to wrap us up for the day. But as mentioned, CGHE and Dr. Stigler Granados will still be on the line for a little bit after that to discuss any further questions. Without further ado, thank you so very much for your time. I'll hand it off to Maria.
Thank you, Julian. So as we conclude today's meeting, I'd like to take a moment to thank Julian for the great moderation and Dr. Stigler Granados for being our wonderful featured speaker. Here are some resources for your review if interested. The recent 4th International Conference of Military Medical Schools, also referred to as ICMMS, provided a unique platform for exchanging ideas with our counterparts worldwide. This event emphasized the importance of collaboration across borders. Linked here are the ICMMS Google resource site and our recently published article on ICMMS on USU News. Next, to support CGHE's efforts, the Federal Research Division of the Library of Congress conducted an in-depth literature review and key findings on the risks posed by health-related misinformation and disinformation, and identified effective strategies to mitigate these threats to health security. From CGHE, the recently published DoD GHE snapshot on critical questions to shape DoD GHE programs and activities, which poses critical questions that will help us shape future DoD GHE efforts. This document serves as a practical guide to ensure our initiatives are targeted and impactful. Next, the CGHE What's Your GHE Story series highlights real-world experiences of GHE practitioners. Our inaugural story, The Value of Trust-Based Relationships, AFRMs, and the Impact of 63 Years of Continuous GHE, highlights rare AFRMs. Lastly, the 3rd Military Civilian Health Security Summit Summary Report, prepared by USU CGHE and reviewed by the US Indo-PACOM Surgeon's Office and the Australian Defence Force. This report highlights key insights from the summit. I encourage each of you to delve into these resources and use them as catalysts for future action. Now to highlight some upcoming events, stay tuned for the upcoming Peers number 5 held on 4 December featuring Indo-PACOM Center for Excellence on Disaster Management and Humanitarian Assistance. The Global Health Engagement Operations course will occur from 9 to 13 December in Bethesda, Maryland, and you can register by clicking the hyperlink, and registration closes 15 November. Lastly, the Fundamentals of Global Health Engagement course will be held virtually 27 to 31 January 2025. A few CGHE updates. Linked here is the CGHE DoD GHE training curriculum one-pager. And finally, if you're interested in CGHE or GHERI calls for white papers, please contact the email listed there to be added to our distribution list. Do you have any thoughts on our peer sessions? Your feedback is very essential, so please help us make our next meeting even better by filling out our short survey linked here. And if you're interested in hosting a peers webinar with us, message us at cghe@usuhs.edu. Along those lines, if you have a GHE topic that you're passionate about, whether it's a success story, a challenge faced, or cutting edge research, we want to highlight your GHE story, so please email us if you're interested. If you haven't already, join the DoD GHE community of practice and become part of the community and learn from the best in the field. Please note that the mil-civ platform is behind a CAC firewall. Also, stay in the loop and subscribe to our mailing list. Email us at cghe@usuhs.edu to be added for the latest announcements to events, initiatives, and hot off the press GHE knowledge products. To conclude, stay connected with us by emailing us and following us on our social media channels. And finally, feel free to stay on if you have any additional questions, but thank you again for participating in Peers number 4, and we hope to see you next time. Thank you.
Thanks again, Maria. Really appreciate the rundown. So once again, thank you all so very much for joining us today. Thank you, Dr. Stigler Granados, for the great lecture and discussion. I know there are a lot of questions that are hoped to be asked, and I don't want to, stand in the way of what I think will be a great discussion. So at this time, I'm hoping to simply go ahead and open the floor. If you have questions for Dr. Stigler Granados or would like to just facilitate or foster a discussion about Chagas disease and the implications for global health engagement, the floor is now open. Please go ahead. If folks don't necessarily have questions that they'd like to ask aloud, we can always go ahead and close out for the day. But Dr. Stigler Granados, one question that I was really hoping to maybe run by you is, I know this is a disease that has been, really changing and developing in terms of its endemicity and prevalence, and where it is that it's manifesting or becoming endemic. And I'm really curious to know. I mean, it's a rapidly evolving disease in terms of how it presents or where it presents. Is there something about Chagas disease that really gets you excited in terms of researching it and understanding, what could be next?
That's a good question. I think everything about Chagas disease always gets me excited because it's such an interesting disease, but I think the lack of awareness is the part that really gets me. My own personal experience was that I had lived in South America for many years in a rural area in Bolivia and other places, and having come back to the United States a decade later, decided to have a family, and I was never asked about my travel history. Nobody ever said, "Oh, did you happen to live in a tent for a year in South America?" Or not even asked me if I'd ever traveled to Latin America for that part. And then shortly after that is when I started working with Chagas disease and realizing, like, wow, there's a complete lack of understanding of this disease, and congenital transmission is something I think a lot about. But I think whenever I think about getting excited is whenever I see light bulbs go on with providers, especially healthcare providers, that seem to be like, oh, wow, I should be really thinking about this with the population that I serve, or, what do I want to do next? And so finding those champions is exciting. And then I think also seeing veterinarians and entomologists that know way more about the disease than our healthcare providers really sparks an interest in me, because I'm like, wow, this One Health idea this is very real with this disease. I mean, extremely real, because when I see when we formed this Texas Chagas task force, for example, veterinarians, military, our entomologists, they showed up in numbers, like mass numbers. And then the human healthcare providers were like 1 or 2. And that's when I realized the burden of the disease knowledge is it's not equitable. Like, I think providers just have so much on their plate. They're worried about diabetes and they're worried about these other chronic diseases, when actually their population could have this other chronic disease that they don't even know about. So I think it's kind of a loaded question for me to ask me what gets me excited about it. But I think the most exciting part is seeing this slow rise in awareness. And as suspected, we're seeing higher prevalence, because now we're seeing more people understanding it a little bit better. So I get excited seeing the changes that have happened over the last decade, which have been huge. And a part of this project has helped with that too. So I think those are really exciting.
Yeah, totally agreed, and it's very challenging, especially to underline the impact of the disease to healthcare providers who are concerned about even things that Chagas disease can manifest in terms of cardiovascular, when you can't directly tie it to Chagas disease if the person, hasn't been screened or developed symptoms that are clearly Chagas disease or anything like that. I do see that my interface is limiting a little bit here, so I do see that there is a raised hand by Cassandra. I'm afraid I can't see your last name, but please do go ahead.
All right. I lost my voice a couple days ago, so let me know if you can't hear me. But my question is, Dr. Granados, do you think you will partner with GHERI again to do more GOG research?
Thank you. I know it's Major Kerwin. I know her well. So that's a great question. I hope so. I think we'd had a really good, what's interesting, this GHERI project, and I know Julian remembers this, we got funded in 2020, literally about a month and a half after COVID pandemic broke out. And so we encountered all kinds of interesting, challenges during those couple of years. So we had to extend it out. But I think regardless, the work that we've done with GHERI, whether we continue through funding mechanisms or not, we're still actively doing the education and outreach, like through this, as well as developing policy materials. We have multiple papers that are coming out about the research that we did. So I think the relationships that we established during this project will last a lifetime. So regardless of funding, I think that the project carries on. It has that legacy that carries on. But Chagas disease, again, it ebbs and flows in its importance with the military. And I'm hoping, I feel like there's this secret list of top 10 things that get funded. And I'm thinking Chagas might go in and out of the bottom of that list. And maybe one day it'll pop back up. But I am looking at partnering with our Namur South people as well, and looking at how do we screen servicemen and women that are being deployed to, for example, Central America. And that's something we're looking into doing as a result of this funding. So I think GEIS is another mechanism that we're working with to help start sort of these screening programs, but everything moves a little bit slowly. So great question, though. Thank you.
Thank you for the great question. Appreciate that. Are there any other questions that anybody would like to share with Dr. Stigler Granados before we wrap up for the day? All right, currently seeing, yeah, sorry, please go ahead.
I'm just going to offer up, I see a couple of places for following up. Anybody who would like to follow up, I'm more than happy. Also, we have quite a few. I saw Josh Bast was on here, and Walter Rochelle. So we have lots and lots and lots of people that are very engaged in this project and this research. But please feel free to follow up with me if you have any questions whatsoever. And if I don't know, I probably know somebody who does. I know next week a lot of us are going to the American Society for Trop Med and Hygiene Conference in New Orleans, where we have a big group of Chagas people that get together. And I'm actually giving a talk on military importance of Chagas disease on a panel there, which will be really great. And thank you, Julian, for helping me prep that presentation, because it'll probably be similar to this. But if you do have questions, I will be with a group of world-renowned experts on this topic and would be happy to float those questions to them on behalf of anybody to help sort of strategize how do we get things moving a little bit faster with Chagas disease. So feel free to email me. I think you have my contact information, but I can put it in the chat just in case. And then if I can be supportive and giving presentations or providing resources or information, I'm always happy to help.
Okay, wonderful. Thank you so much. And yeah, if you need access to Dr. Stigler Granados' contact information, that can also be found through CGHE vectors of communication. So please don't hesitate to reach out if you have any further questions, whether about peers or GHERI or about Dr. Stigler Granados' research. We'd be glad to put you in touch. Okay, seeing no other questions for the time being, I think we're going to wrap it up for the day. Thank you so very much for joining us. It's an honor to be joined by so many colleagues who are hoping to learn more about global health engagement, about Chagas disease, and who are here to join us for this wonderful discussion with Dr. Stigler Granados. Without further ado, we'll go ahead and wrap things up for the day. Have a wonderful day. Take care, and we'll see you for the next peers meeting.